I can assure you that all of us involved in the federal government are focusing on the opioid crisis with the greatest possible intensity. There is no issue that I spend more time on right now as the director of the NIH than this one. And we do believe that science has things to offer here to try to see how we can turn around what is an unprecedented public health crisis. More people dying today of opioid overdoses than died of HIV/AIDS in the United States at the peak of that epidemic. More people dying of opioid overdoses than of car accidents, which we used to think of as the most serious public health threat that we would have to deal with, and we still do. But look at the numbers. It is absolutely daunting, and every one of those numbers represents a tragedy for the family involved, for children that get caught up in this. And we have, I think, the greatest sense of responsibility and opportunity to try to turn that around. It did not happen overnight. You can trace the origins of this, and there were many potential contributors to it. Unfortunately, the medical profession needs to shoulder some significant part of that responsibility with the great increase in opioid prescriptions, which began about 20 years ago in the misguided sense that these would not be addictive for people who were suffering pain, and we now know that that's not the case. So we have a lot to do and a long way to go. But I'm delighted to be here at OSU, and I've just spent the last couple of hours meeting with some of the researchers here who are tackling this problem from a variety of different directions. And I'm very impressed and gratified to see the kind of creativity and energy and resources that are being put into this. And we at NIH aim to try to be the best possible partner we can for those efforts. Opioid use leads to a rewiring of the brain. The idea that individuals who have fallen into addiction, most of whom started with prescription drugs, could simply decide through their willpower that they're going to stop having this particular experience is simply not realistic. We can show, using brain scans, what happens to the brains of people who have been using opioids, either orally or by injection over many months or years. And there is a physical change that leads to the kind of craving that you cannot imagine if you have not been in that particular circumstance. Imagine yourself just basically deciding someday that you're not going to drink water or any other liquids anymore. How far would you get? That is the experience that people have who are addicted. And therefore, we cannot help them unless we offer them interventions to assist with that. The good news is we have those interventions in the form of medication-assisted treatment. There are those who have argued, well, you're just substituting one addiction for another. That is a very unfortunate characterization that is frankly getting in the way of the ability to help people who desperately need help. Programs that utilize buprenorphine or naltrexone or methadone are evidence-based. They will give people the chance to recover. We need to know more about how long that treatment needs to be carried out. And it's not just 28 days, or you're facing an incredibly high relapse rate. So we need to take all of the evidence that's been generated through research efforts, many of them supported by the NIH, and figure out how to implement those across this country as quickly as possible. And here in Ohio, you're sort of a ground zero, as you just heard from Dean Martin, in terms of the statistics. So we particularly want to partner to figure out how to take the talent that's here scientifically and utilize that to turn this crisis around.